Hello, everyone, and welcome. Thank you for joining us tonight for the VMC Animal Health Education Series. We're grateful to have you here, and on behalf of our team, I'd like to welcome you to tonight's presentation. My name is Lauren Kraft, and I partner with clients and clinicians at the Veterinary Medical Center to serve animals and their families. The VMC Animal Health Education Series features our leading experts covering a variety of topics in veterinary medicine, ranging from relevant health information for your beloved pets to ways that we're advancing clinical research that will serve animals and people for generations to come. During the presentation, you can use the Q&A function in Zoom to ask questions. We also asked for pre-submitted questions, and we'll do our best to cover the themes that came up the most frequently during the final portion of the program. Please note that if your pre-submitted question or question for tonight relates to your pet's specific medical care, it is best to call the VMC directly or to have your primary care veterinarian contact our team for a consultation so that we can best serve your family. With that, I'd like to introduce our speaker for tonight, Dr. Borgatti. Dr. Borgatti is an associate professor in the Veterinary Clinical Sciences Department of the College of Veterinary Medicine at the University of Minnesota, a member of our oncology service and director of the college's Clinical Investigation Center. She earned her DVM degree at the University of Torino before completing a residency in comparative oncology and a master's at Purdue University. Her research interests include clinical applications of novel targeted therapeutics and immunotherapy approaches. We're grateful to have Dr. Borgatti with us tonight to discuss her work as a member of the Animal Cancer Care and Research Program. With that, I'll hand it over to Dr. Borgatti.
All right, thank you, Lauren, very much. Allow me to share my screen. Hopefully everyone can see it. Well, thank you very much, Lauren. Thank you to the organizer, and really thank you to all of you for joining me tonight. I'm extremely excited to be here today. I wish we could have met in person. I could have seen all of your faces, but in the absence of that, I'm very grateful that we have the opportunity to at least spend an hour together, and I can tell you a little bit about our program at the University of Minnesota, and also tell you also something about soft tissue sarcoma, so one of my favorite topics. And so let me just open up the presentation. All right, so just a couple of disclosures here. This is an obligatory slide. Wanted to highlight some grant support from the CTSI, the Clinical and Translational Science Institute, the K2R1 transition program that I'm a scholar for, NIH funding that have supported much of the research that we have done for the past few years. A little bit I will tell you about towards the end of the presentation. Intellectual properties, licensing fees and royalties that pertain to a drug that I'll also be telling you about briefly at the end of the talk. It's a drug called eBAT, and Anavive Life Sciences owns the license for therapeutic use of eBAT for all non-human species and applications. And with that, the objectives of this presentation today are, first of all, to tell you a little bit about the Animal Cancer Care and Research Program at the University of Minnesota. So we will talk about who we are, what our goals, our mission, and our vision are. I'll tell you about soft tissue sarcomas, what they are, and how we diagnose these tumors in dogs. And then we will review the therapeutic options that are available for soft tissue sarcomas in dogs, covering some of the conventional therapeutic modalities, so primarily surgery, radiation therapy. But then we will take that as an opportunity to also discuss some of the novel approaches, and so some of the research that we are doing, that we're actively pursuing at the University of Minnesota. So with that, the Animal Cancer Care and Research Program is a program led by Dr. Jaime Moriano. He's the head of the ACCR. And it's a program that fully integrates resources from both the College of Veterinary Medicine and the Masonic Cancer Center. And the vision that we have being in this program, so really where we want to be in the future, is to create a world where we no longer fear cancer. So we recognize and we fully acknowledge that we will not be able to cure every cancer out there, and we will probably not be able to prolong the survival of every single patient, but certainly through collaboration and innovative research that is relevant and that is really responsive to the needs of the clients that we serve and the patients that we care for, we really hope to be able to bring to the clinic new treatments, new strategies that will improve the outcomes of our patients so that a diagnosis of cancer will no longer be frightening for the families that we work with. And then the mission that we have, and this is really the reason why we come to work every day and excited to work every day, is that we want to advance knowledge. We want to make discoveries. We want to learn something new every day. And we want to translate that knowledge into the best possible care for our patients so that we can hopefully reduce the impact that cancer has in our veterinary patients and hopefully human patients as well. And so our primary goal, the most important goal for us, is to really provide outstanding patient care. We want to make sure that whoever comes through the veterinary medical center receives the best possible care that we can provide. That's our number one goal. And we are particularly interested in really studying those tumors that arise spontaneously in companion animals and that share a lot of similarities with a lot of the cancers that arise in human patients. And so we want to better understand the causes. Why do these tumors occur? What drives their progression? What drives them to spread to other parts of the body? How they behave? And hopefully be able to develop these new treatments and new strategies that will improve the outcomes for both animals and humans. And so that is essentially our mission in comparative oncology. And so the ACCR program structure, as I mentioned, is this strong partnership between the College of Veterinary Medicine, which is located on the St. Paul campus, and the Masonic Cancer Center, which is located in the Minneapolis campus on the East Bank. We have this approach of pursuing a comprehensive research investigation spanning from cancer prevention, diagnosis, treatment, and we have a large number of investigators, more than 60 affiliated investigators with different levels of expertise. Some are basic science researchers, others are more translational researchers or clinical researchers, and some, like me, are fortunate enough to have an office in both the College of Veterinary Medicine and the Masonic Cancer Center. And it's an extremely rich and collaborative environment that I feel extremely lucky to be a part of. And the other reason why I feel so fortunate about being at the University of Minnesota is that we can also leverage resources like the Clinical Investigation Center. The Clinical Investigation Center is a crucial infrastructure, and it's also the only one located in the Twin Cities campus that really develops and facilitates veterinary clinical trials with the goal of bringing new drugs, devices, procedures, treatments, that will eventually benefit both animals and humans. And we're able to accomplish this through expertise. We have a lot of faculty members at the College of Veterinary Medicine. They have different levels of expertise, different specialties. We can utilize the facilities, the equipment available to us. And we also provide study coordination and technical staff and technical support. And so I just wanted to spend a moment to show you what the Clinical Investigation Center looks like. This is our structure. A couple of years ago, I was very fortunate to have the opportunity to become the director of the Clinical Investigation Center. We have oversight from the research office, so we work very closely with our associate dean for research, Dr. Molly McHugh, and these are really the people that I look forward to seeing every day and interacting with every day. And just looking at the pictures on the slide kind of make me smile because they make my life so much easier. This is Kathy Subner. She's our research manager. She has been with the Clinical Investigation Center for a very long time before I even became a faculty member in 2008. And I've learned a lot from Kathy for sure in the past 2 years. Dawn is no longer with the CIC, but she still works at the University of Minnesota. And then our nurses, Andrea, Amber, Kelly, and Sarah, they're not only wonderful people, very, very compassionate and caring for our animals, but they're also extremely skilled. They have a lot of talents for sure. And then we also have an advisory board, Dr. Jaime Muriano in this picture here, and Dr. Mike Conzimius, surgeon and also former Clinical Investigation Center director. So we're very fortunate that they agreed to remain on the board and support us through our efforts. So it's a good team. And why are we so interested in soft tissue sarcomas? So let's talk a little bit about sarcomas in general. So these are tumors that are very heterogeneous. So they're very diverse and they're biologically extremely complex. They have different ranges of behavior. They arise from connective tissue, so essentially cartilage and blood vessels and peripheral nerves, fat, all different structures, and they can originate from any anatomical site in the body. Some of these sarcomas are less aggressive than others in the sense that they don't have a particularly high tendency to spread to other parts of the body. And on the contrary, there are some other types of sarcomas that are more aggressive. They are much more likely to spread to other parts of the body. And so there is a huge range of different subtypes, just like in people. And while conventional therapeutic modalities like surgery, radiation therapy are very, very effective in managing, especially the sarcomas that are less aggressive, the challenge really remains for those tumors that are refractory to treatment, particularly those that are coming back following an initial surgical excision. Those tend to be much more challenging to treat and to manage. And because these sarcomas arise from the soft tissues due to the elasticity of the soft tissues, they can be present for a long time before they start even bothering the dog or the patient in general. And so sometimes they'll get to a really large size that will start to impinge on muscles and nerves. But they may go undetected again for a very long time, particularly if these sarcomas are originating from internal organs. So sometimes they will develop on the skin or the tissues under the skin, and so they can be readily visualized and addressed. But in other cases, they arise from internal organs, as we will see, and so they can go undetected for a very, very long time. When perhaps the tumor has already spread widely throughout the body. And sometimes they can be slow growing, sometimes they can be fast growing, but what they have in common is that they are very, very locally invasive tumors. And while they may look pretty well encapsulated and well circumscribed, what is really typical for all sarcomas, both those that are less likely to spread and more likely to spread, they're all locally invasive. They have these finger-like projections, these tendrils that infiltrate really deeply into the tissues, sometimes even invading underlying structures like bone. So there are cases where the bone can be secondarily eroded as a consequence of the enlarging tumors. And those that are considered, as we will see, high grade, and I will explain what that means, have a higher potential to spread and also a higher potential to come back after surgical excision, especially if the surgery is a pretty conservative surgery. And so as we will see, surgery will need to be pretty wide and aggressive to be able to remove all these fingers and all these tendrils. So this is what a typical sarcoma looks like. And as you can see on this picture, there is a lump that is visible on the skin. This is a subcutaneous soft tissue sarcoma, so a sarcoma that arises from the subcutaneous tissue. When we have a dog that comes into the clinic with a lump that looks like this, we cannot assume that the lump will be a sarcoma because there are other malignant tumors, and there are also benign tumors that can look exactly the same way. And so until we test that lump, we will not know exactly what it is. And so there are more diagnostics that are needed to really make that diagnosis. But this is one example. Another example, and this will be maybe a little bit more graphic. If you're eating, you may want to look away for just a second. But sometimes they will originate from other locations in the body, like the oral cavity. This is an example of a large sarcoma affecting the maxilla of this dog. And these tumors are very aggressive and invasive. And like I said, they can invade into the underlying structures and the bone. This is an X-ray that was taken from the mouth of the dog that we saw in the previous slide. And as you can see, the bone is completely gone in this portion of the maxilla as a secondary effect of the tumor eating through the bone. And obviously with such an extensive bone destruction and bone lysis, there is a lot of pain associated with it. Dogs will stop eating, so there will be anorexia, and they don't stop eating because they're not hungry. They are hungry. It's just that their mouth really hurts, and so they don't want to eat because of that reason. And so this is a particular type of sarcoma called fibrosarcoma. And what's interesting about this particular subtype is the fact that if you look at it under the microscope, it may actually appear almost like a benign tumor. In fact, it can be very difficult to differentiate from the benign form called the fibroma. But biologically is extremely aggressive, as you can see from these images. And so it's called the biologically aggressive, and so biologically high grade and histologically low grade fibrosarcoma. So it's a particular subtype that we see in the oral cavity. And then there's some other sarcomas that originate from peripheral nerves. This is an example of a peripheral nerve sheath tumor in this dog arising from a structure called the brachial plexus, which is kind of in the shoulder area and comprised of different nerve tissues that control the front legs. And so in this particular dog, the tumor was impacting the ability of the dog to control movement with that leg. So there was neurological impairment. The dog was not able to reposition the paw, so it had these proprioceptive deficits and was unable to really put weight on that leg. So a lot of pain and lameness associated with it. This is also another type of sarcoma, though, that while it's locally very invasive, it doesn't have a particularly high potential to spread to other parts of the body. So it's considered a lower grade tumor. But then there are also some other types of sarcomas that are highly metastatic. So that means that they have an extremely high potential to spread. They're very aggressive. We call them high grade soft tissue sarcomas. And there's a couple of sarcomas that are pretty much always aggressive that I wanted to mention. They have an extremely high metastatic potential. One is called histiocytic sarcoma, and the other one is called hemangiosarcoma. And hemangiosarcoma is a particular sarcoma type that we are extremely interested in studying. And so our research at the University of Minnesota is really focused on this particular sarcoma subtype, as we will discuss later in the course of the hour. So how do we make a diagnosis of sarcoma? There are several tools that we can utilize. Something that we do fairly routinely in the clinic when a patient comes in with a lump is what's called the fine needle aspirate. So we will use a fine needle we will insert into the lump to remove a few cells from the tumor. And then we put the sample on a slide and we stain it and we look at it under the microscope. And so that's called the cytology sample. And this is what the cytology samples will look like when we're dealing with a sarcoma. There will be all these cells. They have this elongated shape. The darker part is the nucleus of the cell. They're all kind of different in size and shape, and they're high in number. So this is a cytology that is certainly suggestive of a sarcoma. So one advantage of cytology is that it's easy to do. It doesn't usually require sedation. We can do it very quickly. It only takes a couple of minutes to get a sample like this. But the disadvantage is that a cytology sample will not provide information on the specific type of sarcoma that we're dealing with, and certainly will not provide information about the grade of the tumor, so how aggressive or likely to spread this particular sarcoma is. And then there are some unfortunate situations where we do the aspirate and we don't get a very good sample. There are just not enough cells to call a diagnosis. And so sometimes sampling can be unrewarding. The gold standard for diagnosis of sarcomas, and also to better characterize the subtype that we're dealing with and understand how potentially aggressive that particular tumor is collecting a biopsy sample. So with this, we will have to give the patient heavier sedation, or sometimes even do a brief anesthesia, and we will collect a sample of tissue from the tumor. And then we put it in a little formalin jar and we submit it to the pathologist, and they will cut some sections of the tumor. And this is what a sarcoma looks like under the microscope when we do a biopsy. And so the biopsy certainly provides more information. So remember, I mentioned grade, and there is a difference that I wanted to discuss between grade and stage. So there are two different terms that you will hear about a lot. When we talk about grade, we really talk about how aggressive the tumor is when we look at it under the microscope. So this is an information that we gather when we collect the biopsy and we do the histopathology evaluation. And we determine if the tumor is a low-grade tumor, so unlikely to spread, or high grade, so very likely to spread. When we talk about stage, the stage is different because the stage refers to the extent of the disease in the body of the animal. And so to get that information, we need a compilation of several staging tests, so diagnostic tools that will look for the evidence of the tumor in other parts of the body. Sarcomas tend to spread through the hematogenous route, so through blood vessels. And so one of the first targets for spread for sarcomas are the lungs. And so we always want to make sure that we fully evaluate the lungs for any evidence of lung nodules or pulmonary nodules that could be an indication of spread there. And then depending on the location of the sarcoma or the type of sarcoma, we may do additional diagnostics like an abdominal ultrasound if we need to evaluate organs within the abdomen. And then something else that we're doing more and more at the veterinary school is the CT scan or a CAT scan, which is a form of advanced imaging that can allow us to actually evaluate different sections of the body, sometimes multiple sections at the same time. And the CAT scan is actually also very helpful to scan the area of the body where the tumor is located, because it provides additional information on the degree of invasion of the tumor, therefore allowing to better plan the treatment and make treatment recommendations based on that. The grade is a very, very important piece of information where we're dealing with sarcomas, because the grade has been consistently associated with the prognosis. So the grade has been associated with how well the outcome will be for the patient. A grade 1 sarcoma, so a low-grade sarcoma, is a sarcoma that is very, very unlikely to spread, a less than 5% chance. So these are tumors that we can sometimes cure. So a cure is possible for some of these patients that have sarcomas. Grade 2 tumors are considered intermediate grade. Their potential to spread is in the range of about 20%, which is considered low. And so these are also tumors that we can treat successfully. The challenge is with the grade 3 or the high grade sarcomas, because they're much more likely to spread, about a 50% chance. And so for these, in addition to local therapy approaches, we will consider also potentially systemic treatment approaches to try to control the spread of the tumor to distant sites in the body. So when we talk about staging, there are several stages that have been described, with the stage 1 being the lowest, the stage 4 being the highest. So a high stage of disease is usually what we see in a patient that has spread to the lungs or other parts of the body. And so how do we determine that? As I mentioned before, we can do tests like X-rays, ultrasound, CAT scans. This is the picture of an X-ray that was done in a dog with a sarcoma. And just for the purpose of orientation, this is the spine of the dog, and the head is this way. Let me see if I can get the pointer to work. So the head is this way, the tail is this way. This is the heart. Here you can see the lungs should be dark because they're filled with air. But then you start to see all these round opacities kind of scattered throughout the lung field. And so these are all nodules. These are all pulmonary nodules. So in this particular patient, unfortunately, the tumor had spread to the lungs. And it was something that we could see on the X-rays. The CAT scan of the chest can be helpful, and actually tends to be more sensitive than X-rays because it allows us to visualize nodules that are smaller that sometimes the X-rays can miss. And so if your pet comes to the veterinary medical center and we recommend doing a CAT scan, is because that test will be more likely to identify lesions that may be missed with some of the other diagnostic modalities that are available. I guess the downside of the CAT scan is that, because, as you know very well, when dealing with dogs, if you tell a dog, please don't move, I need to do your CAT scan, they will not listen. And so we need to briefly anesthetize them for that test to be performed. Unfortunately, as a fairly short anesthesia, is something that we can do on an outpatient basis. A lot of our patients come in, they will have their procedure performed, and then most of the times they can go home on the same day, but it will be informative. And then in addition to these tests, it's also important to do a very thorough physical examination, blood tests, urine tests, and those are done primarily because we want to evaluate the general health of the patient. We want to make sure that there are no severe comorbidities, kidney problems, liver dysfunction, heart disease, or other things that could certainly impact the treatment recommendations that we make for that patient. Something else that is very important is sample collection. So when we do all these diagnostics, like an ultrasound or a CAT scan, and let's say we do see some abnormalities, we see nodules in the spleen or nodules in the liver, a lot of times there is no way of knowing if what we're seeing is something benign or something malignant. And we don't know if it's associated with the sarcoma or if it could be a manifestation of a different cancer. You know, sometimes, unfortunately, we will diagnose more than one cancer in our patients. So that's something to keep in mind, that we cannot automatically assume that everything we see is associated with the sarcoma. And so the ideal thing to do would be to collect samples from these abnormalities and look at them under the microscope and try to determine if they're cancerous or not. So what are the goals of the treatment? So the main goal is to cure. So we want to cure our patients whenever that's feasible. And the good news is that with some of these sarcomas, particularly the lower grade ones, a cure is achievable if we intervene promptly and if we intervene with a treatment that is fairly aggressive right from the start. If a cure is not possible, we want to try to extend survival of our patients as much as we can, try to prevent the tumor from coming back, trying to delay the onset or the progression of metastasis that may be already there. And then palliation is also very important because there are some situations where the tumor is too widespread throughout the body to do anything too involved or aggressive, but we want to make sure that our patients are as comfortable as possible. So providing pain medications or other modalities that will ensure that we can maintain or improve the quality of life for the time that the patient has, so that they can enjoy time with their family for as long as possible. So surgery, as I mentioned, is a very, very important component of the conventional treatment that we offer for sarcomas. It's considered the treatment of choice. So whenever there is a sarcoma, if it can be removed, that should be the main recommendation. There's some things to keep in mind with the surgery because, as I mentioned at the beginning, these sarcomas may appear very well circumscribed, as you can see on this slide right here. But you may remember that they have all these tendrils, all these finger-like projections. And so if we do conservative surgery and we remove only the portion of the tumor that we can see, it's very likely that we leave all these tendrils behind, and that will cause the tumor to come back. And it's probably just a matter of time. And so the ideal surgery that we should do in these cases, it's a much more aggressive, wider excision where we give a wide margin of what appears to be normal tissue around the tumor to make sure that we include all these tendrils and all the little cancer cells that may be scattered all around. So about 3 to 5 centimeter margins, that's pretty wide, and it may or may not be possible depending on the location of the tumor, depending on the size. So for example, if we have a tumor on the paw of a dog that is wrapping around the paw, there is really not a good way to get that degree of margin. And so the only way to ensure a complete excision in that particular case would be to actually amputate the leg of the patient. And these tumors, interestingly enough, you can see the tumor cells here, they sometimes appear to have a capsule around them. And what it's important to know about this capsule is that the capsule is not made of normal tissue. It's actually a bunch of compressed cancer cells. And so if we're removing these tumors and we leave the capsule behind, that means that we're leaving tumor behind, and likely the tumor will come back. And the fat that may be around the tumor is not a barrier to the cancer cells because the cancer cells can enter into the fat. And so that should also be included in the excision as well. So there are some situations where we remove the tumor, we do a wide excision, we send the sample to the pathologist, and then we will get a pathology report back that says, you remove the tumor, but it looks like you probably left some cancer cells behind. So that may be a situation where we would consider radiation therapy, and it would be an extremely effective modality to pursue at that point, because radiation therapy is very effective at sterilizing residual disease left behind from the surgery. So this is a picture of a radiation therapy machine or linear accelerator. The patients are positioned on this table, and then this arm actually rotates around the patient and delivers the beam of the radiation therapy beam right at the tumor site. And also for radiation therapy, our patients have to be briefly anesthetized because the treatment has to be delivered with great precision, and even a slight movement could cause the treatment to target a different area that doesn't need to be irradiated. We really want to deliver the treatment precisely to the tumor site. There are some situations where it may be a good idea to actually do radiation therapy before the surgery. And so particularly when we have those tumors that are really large and where surgery would be extremely difficult, we may irradiate them first to sterilize the edges of the tumor, which are the most sensitive to radiation therapy, so that when we go back and do surgery at a later time, perhaps we will have a better chance of achieving complete margins. And then there are some cases where we're dealing with tumors that are just completely unresectable. Surgery is not an option. We can likely still do radiation therapy by itself to try to control further growth of the tumor for several months. So the radiation therapy is not a one-time treatment like surgery though. So when we do radiation therapy, just like in humans, we have to do multiple treatments. So the dose of radiation that we want to deliver has to be divided in small, teeny tiny fractions. And those fractions are given on a daily basis for several weeks. And that is a way to minimize any side effects to the tissues that we are irradiating, trying to keep any side effects to a minimum. And then there are some situations where chemotherapy may be appropriate. We usually don't recommend chemotherapy for the lower grade sarcomas unless there is any evidence of spread already. But we generally recommend chemotherapy for the management of those sarcomas that are high grade and much more likely to spread, or sarcomas like Hemangiosarcoma, which we know are always very aggressive. And the chemotherapy drug of choice that we use for sarcomas is something called doxorubicin or adriamycin, which is also used in people. And it's a chemotherapy that attacks rapidly dividing cells. So the cancer cells in the body divide very, very quickly. And conventional chemotherapy drugs like doxorubicin attack specifically those cells. And it's a chemotherapy given intravenously. So we give it as an IV injection every 2 to 3 weeks for a few times. There's also a different chemotherapy approach called the metronomic chemotherapy that uses oral chemotherapy agents that are given at very low doses at regular intervals of time. The mechanism of action is quite different because when we use metronomic chemotherapy, the goal is not necessarily to kill the rapidly dividing cells, but it's to block the formation of cancer blood vessels. Every tumor, in order to grow, needs blood supply. So the cancer needs to make blood vessels to bring oxygen and nutrients to the tumor to allow it to grow and spread. And so this type of approach, the goal is to really block that process and essentially starve the tumor to slow down its progression. So it's a quite different approach that is still really investigational at this point because there are not that many studies available in veterinary oncology. What is a prognosis for dogs with soft tissue sarcomas? It's actually quite variable. It can be very good for dogs that have low-grade sarcomas. In fact, for the low-grade tumors, the expected survival is in the range of years, or cure is even possible, as we said, which is really good news. For the intermediate-grade sarcomas, it's modest to good, so about 1.5 years, sometimes longer expected survival. But for those tumors that are high grade, certainly the prognosis is much more guarded because the life expectancy is shorter than 1 year. Most of the times is in the range of months instead of being in the range of years. And so for those, the treatment tends to incorporate chemotherapy for that particular reason because they have a much higher tendency to spread to other parts of the body. And I just wanted to spend some time and really show you what our work environment is. We work with chemotherapy patients every day. We work with radiation therapy patients every day. And some of you may have seen the oncology space at the Veterinary Medical Center. And just to kind of briefly describe it, we have a big room with the different computer stations where our nurses are based and our doctors also work in this main space. And then there is another side room where we have a microscope. And then there is another room that is dedicated to the administration of chemotherapy. Well, in the first room where we have this bigger space, we actually allow our patients to stay with us. So as long as they are social, they are good with other dogs and they're good with people, we actually let them stay with us in oncology. So we have what I like to call it almost like a little daycare for our pets. And because some of the chemotherapy patients come back at pretty regular intervals of time, they may come back on a day where they see their friends. And so some of them really like to come see us because they get to hang out with people, they get to play, they get to interact with other dogs. And so we really want to try to keep stress at a minimum for our patients. And we really are trying to do our best to maximize their quality of life. And so I just wanted to show you some videos of what life looks like in oncology. And this is another thing that makes me so happy about the work that I do. I'm just so excited to walk into oncology and see dogs interacting this way with the staff. This is Amy, Jessica. We have four-legged patients, three-legged patients. We love them all the same. And it's just a joy to see them play like this. And then a couple of cases that I wanted to show you. This is Sparkle, a 14-year-old Bichon who presented to us for this ulcerated soft tissue sarcoma on the paw. It was very painful. Sparkle received an investigational treatment that resulted in a partial regression of the tumor. And then eventually the tumor started to grow back after some time, at which point Sparkle had an amputation and did great. This is Lena, 13-year-old boxer with a large soft tissue sarcoma that was approached with this wide surgical excision. And I really wanted to emphasize the importance of having good surgeons because in this case, they did an amazing job making a wide excision. They did some pretty elaborate reconstructive surgery. Let me go back. Elaborate reconstructive surgery to close the wound, and she healed remarkably well and had a very happy life thereafter. So some of these stories are success stories that we really like to tell. Now, one of the sarcomas that, as I mentioned, we are particularly interested in is something called Hemangiosarcoma. Some of you may be very familiar with this type of sarcoma, which is highly metastatic, very aggressive, and essentially incurable. It's a type of sarcoma that originates from blood vessel forming cells. It's a tumor that tends to be extremely vascular, so it's usually blood filled. And as far as how these hemangiosarcomas originate, there are several hypotheses, but one thought is that actually the cancer cells originate from the bone marrow, and then after malignant transformation, they localize into different organs of the body. And with the interactions between the malignant cells and the microenvironment, then tumors begin to form. Sometimes tumors form in one organ, and then maybe later in other organs, or sometimes the hemangiosarcoma shows up in more than one organ at the same time. The most common location for hemangiosarcoma to be is the spleen. So definitely the most common location is the spleen, is really where we see the majority of patients having this tumor. The second most common location is the heart, the right atrium of the heart. And then the third most common location is the skin. And sometimes the hemangiosarcoma remains confined to the skin, which is pretty good because we can remove it successfully. But it's much more challenging when it becomes to infiltrate into the subcutaneous tissue or into the muscle, because the more invasive this cancer is, the worse the prognosis is going to be, because it's going to be much more likely to spread to other parts of the body. The reason why we diagnose hemangiosarcoma in the spleen in some of these dogs is that sometimes it's an incidental finding. So dogs go to their veterinarian for an annual exam, and all of a sudden the veterinarian will palpate this large mass in the abdomen. And so that's one scenario. But really the most common scenario is when these tumors get to a really large size and then eventually the mass ruptures. And being so blood filled, what happens is that these dogs may have a massive internal bleeding, and they will collapse, so they will become pale. The owners will bring them to the hospital on an emergency basis. The veterinarian will put a probe on their belly and they'll see that there is a lot of fluid, which turns out to be blood, because there is an actively bleeding mass in their abdomen. And so this is certainly a life-threatening situation that requires an emergency surgery to remove the bleeding tumor. And so in this particular case, since we're talking about a mass on the spleen, then the surgery of choice is a splenectomy, where we remove the spleen and the tumor associated with it. And one thing to remember is that not all of the tumors in the spleen will turn out to be malignant. There's a 50-50 chance. So in the old days, there was this assumption that every dog that would come through the ER with a bleeding splenic mass definitely had hemangiosarcoma, and the prognosis was poor, and a lot of these dogs were actually humanely euthanized based on that assumption. Now it's well known that some benign tumors of the spleen can bleed the same way. And so until we remove the tumor and we do histopathology, we will not know for sure what it is. And so just something to keep in mind. The prognosis for dogs with hemangiosarcoma, unfortunately, is not good, is very poor. If we think about the splenic form, when these dogs are treated with surgery alone, their life expectancy is going to be in the range of about 1 to 3 months. And if we add chemotherapy, then the life expectancy is about 4 to 5 or 6 months. And the outcome is pretty similar for dogs that have the cardiac form, so the tumor on the heart. And for the skin and subcutaneous forms, the prognosis really varies depending on how invasive the tumor is. It may go from a couple of years to a couple of months, really depending on the degree of invasion of the tumor. And so that brings us to all of the research that we are doing at the University of Minnesota, the novel approaches that we're trying to investigate, because we recognize that this prognosis is really not acceptable. We need to do better than that. We need to come up with better strategies to improve the outcomes for our patients. And so one of the things that we have been testing, and that was the main project for my NIH award that lasted a few years, is to study this drug called eBAT. The name eBAT stands for EGF, or epidermal growth factor bispecific angiotoxin. And it's a drug that we gave to dogs, specifically dogs with splenic hemangiosarcoma, in combination with what's considered the standard of care. So in combination with surgery and doxorubicin chemotherapy, which is the traditional way of treating hemangiosarcoma. This is the first study that we published. It was a really big collaborative effort. A big team of investigators participated. And in what we are very proud of is that eBAT is a drug that was made at the University of Minnesota, and specifically at this University of Minnesota Molecular and Cellular Therapeutics facility, which is located on the St. Paul campus, right next door from the College of Veterinary Medicine. And it's a facility that really has this state-of-the-art, good manufacturing practice, good tissue practice, full service development of a lot of cell-based and tissue-based products. And so this is where eBAT was made. And what is eBAT? So eBAT is essentially a cancer-directed toxin, is a drug that targets, and so it binds specifically to cancer cells. And so this is a schematic representation of how the eBAT drug is made. It has 3 main components. One component is a toxin. It's a Pseudomonas toxin, which is represented by this black diamond here. And then this toxin is connected to 2 ligands, which you can visualize as 2 hooks. One hook is called the epidermal growth factor and connects to the cancer cells. It recognizes and connects to the cancer cell. And the other one, called the urokinase, connects to some cancer cells and also to the associated cancer blood vessels. So essentially you have this drug that is attached with these two hooks to these cancer structures. And so when it does that, it delivers the toxin, the lethal toxin, to the cancer to kill the cancer cells. And this toxin has also been modified and de-immunized, meaning that it was genetically modified to try to reduce any potential harm to the patient, because we want to kill the tumor, but we don't want to do harm to the patient. We want to keep the toxicity as low as we possibly can. We have enrolled about 80 dogs in the eBAT trial so far, and we have found that eBAT is actually safe, well tolerated, and it was able to prolong survival. In some of the dogs that were treated, there is a particular subset of dogs that we treated with eBAT who were long-term survivors. And there is still a lot of active research to try to really identify the dogs that are more likely to respond to eBAT than others. So we really don't want to claim that eBAT is a miracle drug, because it's not, but we have definitely seen that it's effective for a particular population of dogs, and we really need to better understand how we can optimize its use in this patient population. Some of the dogs that were enrolled in our trials came from really far away. This Bailey came all the way from the West Coast and California specifically. And so then the owner stayed with Bailey for the duration of the trial, spent about a week in Minneapolis, and then sent us a bunch of pictures of Bailey touring the sculpture garden. We love seeing all these pictures, and we feel so fortunate to have such committed owners that are willing to travel long distances. And so for that reason, one of our technicians in the Clinical Investigation Center put together this beautiful wall art. It's a map where she added all the pictures of our wonderful eBAT treated patients to indicate where they came from. Again, we're so privileged to be working with such wonderful dogs and people who are so committed. A lot of them came from other areas in the Midwest, some from the East Coast, some from the West Coast. And we know all these dogs and we remember them very well. Some were teeny tiny. This is Bella, probably the smallest, little teeny tiny Chihuahua that we enrolled. We had Great Danes, larger dogs. So, and we have this beautiful art displayed in our Clinical Investigation Center. If you ever have a chance in the future, when we have more flexibility without COVID, hopefully soon, to give you a little tour, that would be wonderful to see you there. When we enrolled patients in the eBAT trial, we also had an opportunity to test a new advanced imaging modality, a PET-CT, which is done in people quite routinely, but not so much in dogs. And so we really wanted to evaluate the value of a PET-CT in the staging of dogs with hemangiosarcoma. And we have had 9 dogs who underwent this PET-CT procedure, where we injected this radio tracer. So this radioactive sugar that localizes in areas of the body that are metabolically active. This is the PET-CT machine that is available to us for research purposes at the Center for Magnetic Resonance Research. And this is an illustration that shows you that the PET-CT essentially combines these PET images, so these areas of uptake, which you can see here, with CAT scan images. This is a transverse view of the chest of a dog. The heart is here. These are the lungs. There is a little abnormality here on the heart that we can see on the CAT scan. There's some uptake in that same area. And this is what the PET-CT image looks like. This bright yellow spot is cancerous growth in this patient. And this is certainly an area that was missed with the conventional diagnostic tools. This is again a PET-CT from the same patient. And I'm not able to play this video for some reason, but this is the PET-CT. The dog is positioned almost in a Superman position with the front paws right here. And this is a sagittal view. The head is here, the tail is here. This is the heart, and you can see again this bright yellow spot right here. It's the cancerous lesion that was missed on the x-rays. And this is another view of the same patient. The head is here, the tail is here, again with this uptake at the level of the heart. And then there are some areas like the brain that normally take up that radio tracer, and so that is completely normal. When we started to plan our work with eBAT, we also started a discussion about potentially developing a test that would allow us to identify cancer-associated cells that we could use as a potential biomarker. And so that led us to the design of the Shine On study. And this is a study that is led by Dr. Jaime Moriano, and is also been ongoing for quite some time. And the goal of this particular study is to develop a test which we call the Shine On Suspicion test, which is based on blood collection. So we collect blood samples from these dogs, and what we're trying to identify is the presence of these hemangiosarcoma associated cells. And through artificial intelligence algorithms, this test is able to place these dogs that we are screening in a low risk category for future hemangiosarcoma development, or in a high risk category for hemangiosarcoma development. So far, we have enrolled more than 200 dogs, particularly breeds that are susceptible to hemangiosarcoma development, like boxers and Portuguese water dogs and golden retrievers. And what we found so far is that of the dogs that are placed in the low risk category, these dogs, the 90 to 95% of them are still free of any cancer 1 to 2 years later. But when they're placed in the high risk category, 85% of them will eventually develop a malignancy within a year from the test. And so we will continue to monitor all the dogs that have been enrolled so far, essentially for life. And we will try to determine the time horizon of this test. So we want to try to find out how long is it good for, how often we should repeat it. And we want to pair this test with a treatment like eBAT for early prevention, for prevention of hemangiosarcoma development. So essentially treating these dogs that are in the high risk category with a drug like eBAT to prevent the formation of cancer in the future. So this is work that is ongoing. So stay tuned for future updates. There are some other very active areas of research. We have another study going on, currently enrolling for dogs with splenic hemangiosarcoma that is evaluating the combination of propranolol, so a drug that is normally used for hypertension, so to control blood pressure and heart disease, anxiety, with standard of care surgery and chemotherapy for the treatment of hemangiosarcoma in dogs. The study is called Prognosis, led by Dr. Erin Dickerson. She has done a ton of work in the lab that allowed us to design this clinical trials. And we're doing this in collaboration with Purdue University and Penn. Dr. Liz Pluhar also had a study going on looking at dogs with splenic hemangiosarcoma, investigating vaccine for these dogs. Dr. Valera and Dr. Lawrence will eventually test the combination of radiation therapy and then an immunotherapy drug called the TRIKE, or tri-specific killer engager, for dogs with soft tissue sarcomas. This is something still in the planning that will be available in the next few months. And then something else that I'm actively working on in collaboration with Dr. Modiano and Dr. Valera and Dr. Bruce Walczek and Dr. Jimmy Wu is an effort to really develop an adoptive form of therapy using natural killer cells. And so this is the last slide of my presentation, but I just really wanted to spend a few seconds talking about this project because I'm extremely excited about the potential that we have to leverage natural killer cells to kill cancer, sarcomas, as well as potentially other cancers in the future. These natural killer cells are a type of lymphocytes, so they're a type of white blood cells that belong to the immune system. So people have natural killer cells, dogs have natural killer cells, even though they represent a very, very small percentage. And so what we're trying to do is to expand them and make them more efficient at recognizing cancer cells so that they can attack cancers and kill cancers in a way that is very targeted and very potent and effective. And so I just really wanted to play this video, and I'm not sure why it's not playing. I'm wondering if I can try to change this. It's not playing. Let's see. I'm trying to see if there is a way to. It's not playing, but it's a really cool video. Let's see, I just want to try one more thing. Okay, let me try one thing. No, I don't think it's gonna play, but that's okay. It's a really cool video because what it shows you is actually a natural killer cell that is this blue cell right here that attacks these cancer cells, and when it attacks them and it actually kills them, they turn orange. So it's a very, very cool video to see, and so I'm going to try to play maybe later. We'll see if we're able. And so just to finish, I just really wanted to acknowledge a large number of investigators that have been involved in all of our research projects. The Walczek Laboratory, the Valera Laboratory, the Modiano Lab, the Dickerson Lab, all the staff at the Clinical Investigation Center, the clinicians and staff at the VMC in Oncology, but importantly, really all of the dogs who have participated in our clinical trials and their owners who brought them to us. And I certainly would like to acknowledge the funding sources that have provided the funding to complete some of these projects. Some of them are still ongoing. Individual donors, we really appreciate all of your support. Philanthropy always is appreciated because it really drives our work and allows us to come to work every day and make new discoveries that hopefully will translate into better care for our patients. And if you are interested in discovering ways to be involved, you can contact Lauren. And with that, I will take any questions that you may have at this time. This is my cat, Amelia, and I just wanted to include a picture of her to illustrate that. Well, first of all, she always wants to feel included, so I didn't want to leave her out. But also because we have been talking about dogs, but we love cats very much too. We don't have any clinical trials at the moment in cats, but hopefully we will in the near future, so that hopefully future talks will be geared towards our feline patients as well. So thank you very much for your attention, for participating and tuning in. And with that, I will answer any questions.
Thank you so much, Dr. Borgatti, for such a good presentation. Certainly a lot to learn. I know we're running a few minutes over, but we definitely want to include some questions. So if you are able to stay a couple more minutes, we will get to those now because there were a lot of great ones that you submitted. So the first question that we received for you is, what preventative measures can I take to mitigate the chances of cancer or ensure that my pet is in optimal health throughout their lifespan?
Yes, that is a good question. It's a common question that people ask. And really, well, there is no good way to completely prevent cancer in any patient, because that is something that can just happen, and the chance tends to increase as the age increases. Making sure that our pets are well cared for, evaluated by a veterinarian regularly. They are kept active, and also offering a good, balanced and complete diet. These are all very, very important things to remember. And I think really importantly, regular visits to your veterinarian and following recommendations.
Sure, yeah. Another question that was fairly common that came up is, what are symptoms or possible ways to identify tumors in our pets?
Yes, there are several things to watch for that any of you can do at home that can alert you about the potential presence of cancer. There are several signs to look for. They're not specific for cancer in any way, but things to watch for are, for example, swollen glands, like swollen lymph nodes. If there is any enlargement under the neck, in front of the shoulders, these could be swollen lymph nodes that would need to be evaluated by a veterinarian. Lumps and bumps, especially those that are changing, they're growing, they're becoming harder, they're changing in size or consistency. Things like persistent vomiting, diarrhea, or a cough, like a dry, non-productive cough, could be potentially a sign that there is something going on in the lungs. Bleeding from natural sites, so bleeding from the nose, bleeding from the genital urinary tract. Those are things that could potentially be a sign of cancer in some of these structures. And so something to consider bringing your pet in for. A bad odor that is coming from the mouth could potentially be a sign that there is a growth in the oral cavity somewhere. Straining to urinate, straining to urinate or blood in the urine. This is something that can be seen with regular urinary tract infections, but certainly when the signs don't go away with appropriate antibiotic therapy, medical management, then that would prompt additional diagnostic tests or additional investigations to find out if there is an underlying tumor somewhere.
Okay. And then another question that we received is, what can I do to help a dog have a good quality of life with a diagnosis of a sarcoma or cancer?
Mm-hmm. Yeah, quality of life, as I mentioned, is the utmost concern. We want all of our patients to have a good quality of life. And we try to make that happen regardless of the treatment that we provide. Some of the treatments that as we have seen, tend to be fairly involved and potentially aggressive, certainly it can be viewed that way. But making sure that we are on top of things as far as pain management, so using pain medications, that is very important. And it's important to be proactive because our patients are extremely stoic. A lot of times they don't complain, they don't tell us that something hurts. But we can see an improvement once we provide pain relief and we intervene at an early stage. When we have animals with painful masses in their mouth, intervening early is always better than waiting until they're really starting to show signs of pain and discomfort. There's some additional palliative treatment modalities. When we talk about radiation therapy, for example, the treatment can also be delivered with palliative intent. Usually the treatment is much shorter, so there are not as many fractions as when we treat tumors with a more definitive intent. So the treatments tend to be shorter, and the goal is not to cure anything or control anything long-term, but it's really to try to provide some pain relief for some time in conjunction with pain management and medical management for these patients.
Okay. Probably have time for one more question, and this is more on the topic of clinical trials, which I know you referenced at the end of your talk. So are there any advancements in using beta blockers as a treatment option for a specific form of sarcoma?
Yes, so that's a good question, and thank you for that question, because it allows me to expand a little bit on the Prognosis study that I briefly mentioned. And certainly that is a topic that could potentially take another hour of presentation, which we don't have. But beta blockers have been repurposed. So drugs like propranolol, which is used for cardiac disease and blood pressure, or even anxiety, as I mentioned, have been repurposed for the treatment of cancer. And in humans, it was recognized that they can be effective at managing some benign and also malignant vascular tumors, which is what led us to our trial. And so far, we have enrolled about 10 dogs in the Prognosis trial. And so the study is really ongoing. We are very optimistic by what we are observing in our patients, but still definitely too early to draw any conclusions. And so we need to enroll more dogs and put all of the data together and then share it with the community once that data are available in the future. So just continue to stay in touch for updates, and we are really looking forward to see where that study goes.
All right, well, thank you to Dr. Borgatti for your presentation and your insights, and thank you to our many participants who shared such thoughtful questions in advance and during the presentation. As always, the VMC is here for you 24/7 to help care for your pet, so please don't hesitate to reach out to us after tonight. And next month, this series will welcome Dr. Sandra Cook, who will present on common dermatological conditions in dogs. So if you enjoyed learning about our team's work tonight, we encourage you to visit our website or reach out to us directly to learn more about our mission to improve the health and well-being of animals and people. And we hope that you will consider supporting our team in the work that we do to serve animals of all shapes and sizes. And thank you again for attending tonight. We hope to see you next month.
Thank you very much. Bye.